I'm Bob Haws. I'm really pleased to be able to speak to you today. I'm a pediatric nephrologist or children's kidney specialist at the Marshfield Clinic Medical Center in Marshfield, Wisconsin. And many of you have had the opportunity to come and join us here to be seen. It's a real pleasure to be able to speak with you today about one of the things that I'm really interested in is the care of individuals that have Bardet-Biedl syndrome.
Awesome. So we will get started with the questions. First question is bone and muscle pain in the hip, lower back, and legs normal?
Well, it's never normal to have pain. So I want to say it's not a normal thing. Having said that, it is something that surely it happens to many individuals with Bardet-Biedl syndrome. So I wanted to kind of spend some time talking about that for a few minutes. So we know of a number of abnormalities of the muscles and bones of individuals with BBS. One of the most common ones, of course, is extra fingers and toes, and that's part of our musculoskeletal system. And so extra fingers and toes are found about 80+% of individuals with BBS. But also there can be other findings. So for instance, there can be curvature of the spine, which we call scoliosis. That occurs in about 20% of individuals with BBS, and that can cause hip pain, back pain, lower extremity pain. And so that's one thing that's quite common. And unfortunately, the individuals with BBS that have scoliosis have a higher rate of needing surgery to repair it. Also, there can be issues with the hips. There can be something called hip dysplasia, where the joint in the hip bone is not quite right. That may require some surgery. There are individuals who have one leg that's shorter than the other leg. That's called leg length discrepancy, and that's relatively common in individuals with BBS. There can be something that's called Leg-Perthes disease, which means that the blood flow into the what we call the femoral head, or the as you know, the leg bone goes into the hip socket, and sometimes the blood flow into that can be a problem. That's called Leg-Perthes disease. There's something that's called Blount's disease, which is a problem of the growth plates. Oftentimes the leg bones can have a curvature to them, which we call genu-valgum, and that can lead to problems and hip pain and leg pain. And finally, there can be foot issues, especially flat foot, which can lead to hip and leg pains because of the flatness of the foot and shoes that don't fit quite properly. So I name all those different things, not because I'm saying that that is always the cause of that person's hip pain or leg pain or whatever muscle pain, but to say that it's complex. And I really encourage that individuals that are having hip and leg pain, they see a orthopedic doctor or a physical medicine and rehabilitation doctor who would be very competent at figuring out what that pain is and what they should do about it. So I highly encourage a comprehensive musculoskeletal examination of children, adolescents, teenagers, adults with any type of musculoskeletal pain.
We'll move on to the second question. When will Setmelanotide be FDA approved? Is this a prescription from the family doctor, and how expensive is it?
You know, I think I probably have had more experience with giving Setmelanotide than any other physician I know in the world. And so I'm very excited about Setmelanotide. It is made by a company called Rhythm Pharmaceuticals. Setmelanotide is currently approved for 3 conditions that do not include Bardet-Biedl syndrome, and that's in the United States through the Food and Drug Administration. We anticipate that it will be approved by the Food and Drug Administration sometime in 2022. I will defer completely to Rhythm Pharmaceuticals to decide or to probably project a little bit better when they think it'll be approved. Setmelanotide is currently given as a once-a-day shot. There is investigations that are going forward to look into giving it once a week. That might be more convenient for individuals. There are investigations on how to deliver it better, perhaps through a administration pen, as some of you that might know a little bit about insulin and insulin delivery, that there's pens that can be used to deliver it. And that's surely being investigated. Does it work? Yeah, I think it works really nicely for many people, resulting in a decrease in appetite, in weight loss. The weight loss is not huge. So in other words, you don't lose 20 pounds in a week, but it's a gradual ongoing weight loss that we see that's quite effective with several individuals in our studies over the last few years that have lost up to 100 pounds and seems to be nicely effective. It does cause increased darkening of the skin, which kind of gives a person an appearance of a suntan. For some people, it could be more darker suntan than others. It depends a bit on your complexion naturally. So if you're a fair-skinned individual, it would be a little bit less than if you're a darker-skinned individual, where the darkening of the skin will be a little more prominent. That does go away once you stop the setmelanotide.
Okay, sounds great. Third question. Can a diagnosis be made when only one copy of a gene is mutated and the children have few primary characteristics but multiple secondary characteristics?
What a wonderful question. That really is a question that's challenging. I think Erica Davis, who is a wonderful researcher in the genetics of BBS, will be able to give some insight. So currently, Bardet-Biedl syndrome is based on clinical diagnostic criteria. Those criteria were first published by Dr. Philip Beals in 1999, with some updates and papers that have come out subsequently from Dr. Beals and his group. There are primary characteristics that are seen, and then secondary characteristics. Some of the primary characteristics that I feel much more comfortable about saying this is BBS include the presence of retinal degeneration, which sometimes called rod cone dystrophy or cone rod dystrophy. That is fairly common in individuals, but not universal. The presence of extra fingers or toes on the pinky side of the hand, so on this side of the hand, or on the pinky side of the foot, is very characteristics of BBS, but not always seen. Learning difficulties are common, but again, not universal. Kidney disease is something that I look for as a kidney specialist, but there's surely individuals with BBS that don't have kidney disease. In males, there can be small penis or small testicles. It can be characteristic of BBS and help us with the diagnosis. And various learning difficulties are common with BBS. There are secondary features of BBS, such as speech difficulties, dental abnormalities, congenital heart disease, just to name some of those that have been cited. And so we typically look for the primary characteristics, or 3 of the primary characteristics plus 2 of the secondary characteristics. And those features can be found both in Dr. Beal's paper, also on our website and the CRIBS website, www.bbs.registry.org. You'll find those characteristics of the condition. And pretty much anywhere you might look on the internet should have the characteristics. Now the question was, can someone have BBS with only one known gene and the second gene not being identified, but having sufficient diagnostic features to make a diagnosis of BBS? The answer is yes. So the number of genes that we are identifying with BBS continues to grow. Currently, I know of one genetic testing company that tests for 28 different genes, and that I anticipate that will continue to grow. In a paper that we'll be publishing pretty soon, there'll be several new genes unique to BBS that will be published. So yeah, one could have BBS without having a definitive genetic diagnosis. Matter of fact, it is commonly published in various papers that 15 to 20% don't have genetic diagnosis. We also know that there are individuals that could have a single gene, that there may be a second complementary gene or a second gene that's not identified on the current genetic techniques to find them. So I guess the bottom line, what I want to say is BBS is still diagnosed based on diagnostic criteria. We surely love when we have genetic confirmation of the diagnosis, but that's not always there.
Moving on to question 4. How much water should someone with BBS, especially a child, be drinking? Is it possible to drink too much water?
Good question. So the first question, I'll answer the second half of that question first. No, I don't think you really can drink too much water. There's some rare conditions not from BBS where people have what's called cyclogenic polydipsia, where they drink huge gallons and gallons of water a day. And they can get themselves into low sodium states that can actually potentially put them at risk for seizures. But otherwise, it'd be very uncommon for a person that drinks 1, 2, even 3 gallons of water a day to get themselves into a situation of that sort. Now, in Bardet-Biedl syndrome, there's evidence to suggest that drinking plentiful amounts of water is helpful and protective for the kidneys. That evidence stems from a different disease, BBS is a ciliopathy or disorder of the cilia throughout the body. There's a different disease called polycystic kidney disease. And we know that in that condition, which is the most common ciliopathy, we know in that condition that drinking large amounts of fluid help protect the kidneys. And so I tell my teenage patients with polycystic kidney disease, they should drink at least three liters of fluid a day. That's 100 ounces of fluid. I do that with my patients with Bardet-Biedl syndrome also. I tell them to shoot for 100 ounces a day. In younger children, I kind of taper it down a little bit. So in a 10, 11, 12-year-old patient, I would still like them to be drinking 75 to 80 ounces of fluid a day. As they become younger, it's more on the amount that you can encourage the child to drink. But I would still love to see even young children drinking 30 to 60 ounces of fluid a day, preferably closer to 60 ounces, because I do think it's helpful to the kidneys and should be encouraged.
Moving on to question 5. If a person with BBS hasn't developed serious kidney disease by the time they are a teenager or young adult, how often do they need to see a nephrologist? Are there specific things they should be tracking?
That's a great question. So I've mentioned several times about the website, www.bbs-registry.org, where we collect information through the clinical registry investigating BBS. I encourage you to be part of that because the information I'm going to share with you now has come very much from that information that you've shared with me as a researcher. We know that there's certain genes in BBS that are more prone towards kidney failure than others. So there's a number of genes that continues to grow, approaching 26 to 28 genes that can cause BBS. BBS1, which is the most common cause of BBS, is relatively uncommonly associated with kidney failure. But it does, and some people lead to kidney failure, and sometimes even very young during the early years of life. On the other hand, BBS10, which is the second most common cause of BBS, is the most common gene associated with kidney failure. And so knowing genetics and those features help us kind of tune ourselves in towards kidney disease. But also, we've also found that the majority of people with kidney failure do go to kidney failure before 20 years of age, and the vast majority before 30 years of age. There are some exceptions of individuals who've gone to kidney failure later in life, but most during the first 30 years of life. So the question is, what do I do if I'm 20, 25 years of age and my kidneys are doing really well? Do I need to see a kidney doctor each year? My answer to that is no. But having said that, I also want to point out some important things that will affect that. The individuals that I see as a kidney specialist that have kidney disease other than Bardet-Biedl syndrome often have a lot of protein in their urine, a lot of blood in the urine, high blood pressure. They get fatigued, they lose their appetite, and they just kind of get what I call the dwindles. That does not happen with Bardet-Biedl syndrome with kidney disease. So I see individuals with advanced kidney disease who still have a great appetite. They may have very little protein or blood in their urine. Their blood pressure might be a little bit elevated, but often controlled with one medication. They don't have very severe anemia, which is lack of white red blood cells, which is classic of kidney failure. And their energy level is pretty similar to what it's always been. And those individuals could be missed unless they're seeing their regular doctor. So I encourage you to every year, regardless if your kidneys are functioning well or not, to have a simple blood test called a creatinine and a urine test called a urinalysis as the most basic testing that should be done annually. Now, usually your doctor will probably do more than that, but that should be done. Your blood pressure should be checked to make sure your blood pressure is well controlled and within normal range, and should be treated if you have high blood pressure. Those are the basic things that should be done every year. So again, what I'm saying to you is that there are some genes that are very commonly associated with kidney failure that need to be closely monitored for kidney disease. There's some genes less likely, but still we see leading to kidney failure. So please be sure and keep on top of it. But if your kidneys are functioning well at 20, 22, 25 years of age, your checkups can be done through your primary care doctor with the testing I mentioned.